Good morning, I'm Dr. Michael Simonis. I will perform a clinical examination of the shoulder. I would like to thank my wife for assisting me. So, hello, I'm Dr. Simonis. I will do some tests on your shoulder. Sometimes I will check the other shoulder for comparison reasons. If at any point you have pain or discomfort, you should just tell me and stop me. Okay, so first thing I would like you to do is to just drop your so that I can see your two shoulders. So first thing to do is inspection. Um, for inspection, I will just look for any muscle atrophy or any evident anatomic problems like acromial elevation in cases of clavicular elevation in cases of acromioclavicular joint sprain. We can look for kyphosis and postural things that could contribute to problems with shoulders. Thank you. Probably then I will continue with palpation of the certain anatomic structures. I will start with palpation of the sternoclavicular joint right here. I will continue palpating the clavicle. Sometimes when there is a history of a clavicle fracture, we can actually feel anatomic differences between the two clavicles. And I will then palpate the acromioclavicular joint for any pain or discomfort. Then I will palpate the tendons of the rotator cuff first. I will palpate the long biceps tendon, which is a cordon-like structure. Sometimes if we press a lot, it can be painful even if there is no pathology. I always compare to the other side. Then I will palpate for the subscapularis after making a passive external rotation of the shoulder, so that the subscapularis tendon comes in front. With a slight internal rotation, I will palpate for the supraspinatus tendon, and then go a bit backwards for the infraspinatus and teres minor tendon. And sometimes I palpate if I see some atrophy. I will palpate for the muscle belly of the supraspinatus, which lies in the supraspinatus fossa, and infraspinatus, which lies in the infraspinatus fossa. Thank you. You can turn. Then I will check for range of motion of the shoulder. I always check first the active range of motion, and then if active range of motion is not normal, I will perform myself passive range of motion. I will just ask you to do this movement with both hands. The maximum you go all upwards. So this is the anterior flexion of the shoulder. Then I will ask you to do abduction. So you just do this movement the most possible. Okay, great. Then I will check for external rotation. So you stick your elbows on your sides, and then you do an external rotation just like that, the maximum that you can go. Great. And then I will check for internal rotation. So I will ask you to put your hands backwards and upwards, the most upwards possible. So here we can see internal rotation, just like that. And we can actually measure using where the thumbs reads the vertebra body or spinal process that the thumbs reads, to measure the internal rotation. Thanks. So this is the active range of motion. And then I will check for, I will do some tests for each of the rotator cuff tendons. And the long biceps. I usually start with the long biceps tendon, just so that I will not forget it. So can you just please, yeah, okay. So the long biceps tendon, I just do the Spitz test. So this, you just have your hand like your elbow always extended, and you push upwards, and she should, if there's any pathology on the long biceps tendon, she should feel a pain here with this test. Then I will check for the subscapularis tendon. Subscapularis tendon, I usually do the belly press test. So I will ask you to just put your hands like that and press your belly. And if there's any pain, she should have some pain here if there's any subscapularis pathology. And for subscapularis, I also do the lift off test. So I will please stand like that and put your hand behind just one hand like that, and you push my hand backwards. Go on, go on. And so she has a lot. I compare with the other side, and if there is any difficulty to perform this test, maybe there is a subscapularis rupture that needs MRI investigation rapidly. These tests for subscapularis, and then I will check for the supraspinatus, which is the most common tendon with pathology. So I usually perform the empty count test. So you just have an abduction of 90 degrees, internal rotation like that, the thumb pointing downwards, and you just push upwards against my resistance. So this can cause pain at the shoulder region. Maybe if this is the case, maybe there is some pathology with supraspinatus tendon. Infraspinatus tendon and teres minor is just resistance to external rotation. So you just do this movement against my resistance, and that's how I test for all the tendons surrounding shoulder. And then I will, if history is indicative of any instability, usually what I do is the apprehension test. So it's abduction, external rotation 90 degrees, and right about here, if there's apprehension, the patient will stop us. So he will tell us, just stop. I'm very afraid of my shoulder popping out of the socket. That's what I will do for instability. If it's positive, and if then I will do other more specific tests for instability. And for labral tears, I do the O'Brien's tests, which is the shoulder in 90 degrees of abduction and about 30 to 40 degrees of adduction. And I will ask her to fully pronate and just do a movement upwards and with resistance. And if it's painful here in the shoulder, it can show a problem of a labral tear. And if it's positive, and if history, I'm very suspicious of labral tear, I will perform more tests for this condition. I will also test for scapular dyskinesia. This is a bit. I do several tests. Here I will just show a simple test. So I will ask you to turn around like that and just do continuous abductions like that. And I will just see the scapula and see if there is any dyskinesia, any imbalance, which could cause problems. Thank you. In some sport-specific situations, I will ask the patient to reproduce his movement and recheck the kinetics of the shoulder, just to be sure that his technique is right and there is no suspicion of any anatomic structure that could be overused or things like that. Finally, and it's a thing that I unfortunately sometimes forget, it's the tests for acromioclavicular joint problems. Palpation, I found that it's really very indicative, but also the scarf test. So it's we take the arm and to an adduction, full adduction. No, you can leave it like that. This can cause pain in cases of acromioclavicular joint problems. This is a global assessment of the shoulder. Of course, there are many more tests that we can perform if the first assessment is indicative of certain pathologies. That's one thing. Second thing that we should always think of is that shoulder pain sometimes can be a bit of difficult to differentiate from a referred pain from the cervical spine. So sometimes I perform cervical spine clinical examination just to be sure that it's a shoulder pain problem, and that's how I perform clinical examination of the shoulder. Thank you very much. Thank you.